Coming up today, blocking the blood to reduce joint pain. We learn about a less invasive arthritis treatment for people who aren't quite ready for a total knee replacement. Good morning, I'm Jessica Lovell, and welcome to the Morning Medical Update. Knee pain from arthritis can become a daily frustration. A lot of people turn to painkillers or injections with mixed results. And when the arthritis gets bad enough, surgeons may replace the knee entirely. But now there is a treatment that can bridge the gap, so to speak, between those options. It's more permanent than painkillers, but not as drastic as surgery. And it promises to let patients go home the very same day as their procedure. We are learning more about this technique from Dr. Brandon Custer, a vascular interventional radiologist here at the University of Kansas Health System. Welcome. How are you?
I'm good. Thanks for having me.
Yeah, great. Great to have you with us this morning. We're also talking with one of his recent patients, Melissa Blake. She is joining us from her home alongside her husband, Robert, this morning. Good morning to both of you.
Good morning.
Thank you for being with us. We're so glad to have you. Dr. Custer, the name of this procedure, it's called GAE. First, just tell us what the letters stand for.
Yeah, so it's geniculate or genicular artery embolization. So the geniculate arteries are branch vessels that come off the main blood vessel that takes flow down your leg. And these are, everybody has them, and they're blood vessels that take oxygen and nutrients to those tissues around the knee. Embolization is just our fancy word for blocking up the blood vessels. So what we do is we take a little tiny microcatheter out into those blood vessels, see the abnormal blood vessels that are new associated with pain of osteoarthritis, and we deploy some little tiny microscopic spheres to plug up those abnormal blood vessels.
So it's called GAE. Who's it for?
It's for anybody who has uncontrolled knee pain from osteoarthritis. Usually these are patients who have tried more conservative measures. So whenever someone has osteoarthritic knee pain, they start by getting oral pain medicines. Usually the next step is going to be moving on to joint injections with either steroids or synthetic materials. So those are effective for a lot of people for a long time, but eventually over time their either duration of how long they help or how much they control the pain decreases over time. And there's this gap in people who are underserved where those aren't working anymore, and they're not yet able to get a knee replacement or don't wish to get a knee replacement, and they're right now being undertreated. There's this gap of people who aren't getting their knee pain controlled, and this fits into that category where we can supply an adequate pain relief for those patients.
So take us inside the body, connect the dots. How does blocking the blood flow lead to less pain?
Yeah, it's kind of counterintuitive. Like, why does blocking up this one blood vessel help knee pain? And really what it comes down to is understanding the mechanism of pain generation in the knee. So when people have osteoarthritis, they get pain. As they have that pain, they release inflammatory markers into their bloodstream. And the body responds to those inflammatory markers by creating new blood vessels. We call that neovascularity. These are abnormal blood vessels that most people without osteoarthritic pain don't have, and they go into parts of the knee that don't typically have blood vessels. Along with the formation of those new blood vessels comes the formation of new nerves, which means more pain generation. And it starts this negative feedback loop where you get more new blood vessels, more new nerves, more pain, more inflammation, more new blood vessels, and it starts this cycle. So what we want to do is try to target a way to break that cycle and stop the generation of pain. And the spot where we do that is at that new blood vessel formation.
You call this low risk, high reward. How so?
Well, the low risk side is pretty self-explanatory. We do a very, very minimally invasive procedure. Our entire procedure is done through a little incision about this big, about a centimeter in the groin. Most of our studies show 0 major complications. Minor complications are also very, very rare, happening less than 1% of the time. There's only really one complication that is commonly seen, and that is a little splotchy rash in the skin around the knee that's completely self-limited. It gets better on its own within a couple weeks. It doesn't hurt, it doesn't itch. It just looks a little funny for a couple weeks. So in that way, it's very, very low risk. As far as high reward, we now have a lot of good data that shows significant improvement in pain and a significant improvement in pain that lasts for an extended period of time. So that's a very high reward, but mostly it's people who are otherwise untreated, right? So there's people who are having uncontrolled pain that's really limiting the quality of their life. So the reward of getting that improvement in pain, even if it's only a moderate improvement in pain, allows you to do the things you want to do and improves your quality of life.
And we're going to hear firsthand from one of your patients, Melissa, here in just a moment. But explain for people who may not understand, what is that quality of life that some of these patients are missing out on?
Yeah, and as you said, Melissa's going to probably be able to speak to this better than me, but we see so many patients who are at a stage of knee pain where their pain is so uncontrolled that they can't do things not only that they don't want to do or that they wish they could do, things that they need to do. Talking about being able to walk around the grocery store or go on errands and walk to and from the car, play with their family, play with their grandkids. They're not able to do those things, and it's really a detriment to their quality of life. And that's what we're trying to give these people back with this procedure.
Well, before she got this procedure, we asked Melissa about how this impacts her life. While she was in the pre-op area, Melissa told us that gels and injections were working for a while, but recently things were getting more and more painful.
I've got to do something different because I just can't be like this. And so I was really glad that, since I wasn't a candidate for knee surgery, replacement surgery, that this was an option. And I'm really hoping it'll help because, gardening season's coming up. I need to get stuff planted.
She can force herself through it, but then she'll lose the next 2 days. So, we have to go see the grandkids. They have a concert or a play, right? So we do that, and then get the parking we need, and she hikes all the way in, she hikes all the way back out, and the next day she doesn't move because her knees are killing her.
Well, that puts it into perspective. Gardening and grandkids, two very, very important things, Melissa and Robert. Thanks for joining us. Melissa, how long have you been living with this knee pain?
A long time, I would say at least 15 years, but it's gotten gradually worse. Arthritic pain isn't something that just, one day you're disabled. It's something that you kind of get used to the pain, but it just keeps increasing until suddenly you just can't do the things you need to get done.
So starting back from the beginning, what things were you trying in the beginning?
Well, there's ibuprofen, and things like that. And then when it started, that didn't help. I went to see a doctor, and they used the gel injections, and that I had that done, and that worked for years. That really helped. But then, that stopped working too. And because I wasn't a candidate for knee surgery, knee replacement surgery, I was like, I just can't. Something has to happen because I can't just, not do anything. I have 6 grandchildren, but I have 3 that are under the age of 2, and my daughters need me to be able to babysit, and I need to be able to chase these little guys down because they're running. I need to be able to at least move fast.
Well, that was my next question, is how is this impacting your life? And I think that sums it up in the biggest of ways. What are some other small ways, though, that this was affecting your life?
Well,
I would imagine just getting around grocery stores and just some of those day-to-day things that we all take for granted, right?
I'm in the middle of a kitchen remodel, and we were going to warehouses to look at countertop slabs. And they had to take a wheelchair for me because I knew I wouldn't be able to walk all around a warehouse, which, I don't want to be in a wheelchair. I don't want people to have to push me around. That's not the way I want to live my life. But it was also, they didn't want to have me, saying, I've got to find a chair. I can't go any further. It just wasn't, I just wasn't living the life that I needed to live.
Robert, from a partner or from a spouse's perspective, what was this like, kind of watching Melissa gradually deal with this over time?
My sister-in-law lived with us. She was mobility challenged, so I had a heads up of what was coming, so to speak. But the partner's job is that, or I feel the partner's job is, I count her steps. I make sure that she gets dropped off close to the grocery store doors, right near the mobility carts. I carry her purse. I discuss with her. I do not tell her, but do we really need to do 3 stores in a day? Maybe you just do 2 stores today and do another one tomorrow, so that you don't wreck your knees. Because like you saw in the video at the pre-op, she can eat. She's a nana. She's not going to miss the concert. But if she's got to walk a quarter of a mile in from the parking and walk a quarter of a mile back because there's 1,000 cars in the parking lot and we can't drive the car up to pick her up, she's going to do it because Lord knows she's a nana. She's going to love her kids, but grandkids, but then the next day she can't do anything. And so my job is to make sure I'm sort of the tractor. Is this important enough to do today? You got to get it done. You got to get all the life things done. But you need to do this today. And we do the countertops and the furniture for the kitchen today, and then we do floor tiles tomorrow.
Yeah.
So that she can get spread out and on Sunday she can still do something.
Well, I hear you saying you're just trying to strategize how to live with this in some ways, and trying to figure it out. But it sounds like at some point you kind of get fed up with doing that. How did you learn about this GAE procedure?
Well, we had gone in to see an orthopedic doctor about maybe getting something different, and she had suggested this new surgery to me, and I was like, well, anything, because what I've got right now is nothing, and it's not working. So yeah, I was excited to hear of anything else that might be done.
So you go in for procedure day. What was it like? What were you expecting?
Well, it was the procedure itself was really it was pretty easy. There wasn't a lot of pain associated with it afterwards. I was, it was really pretty easy. And I have known people who've had knee replacement surgery, and I was like, this is a lot better than, spending weeks, not being able to do anything, because while there is a weight restriction for, a little over a week, so I wasn't picking up my grandkids for a while, but it wasn't anything that was too difficult to do. And like I say, there was no pain or anything. It was really easy.
Dr. Custer, can patients expect a pretty easy day and get out of there same day?
That's the big difference between us and bigger surgeries like knee replacements, right? So we have a same day outpatient procedure. So they'll come in that day, leave later that same day. Our whole procedure is done under something called conscious sedation. So with conscious sedation, we give people an IV, we give them medicines through their IV to take away pain and anxiety, help them be comfortable during the procedure, but we don't use full anesthesia. They don't go all the way asleep, don't have to put tubes down their throat to help them breathe or anything like that, like you do with a big major surgery.
I think we have some footage of you performing this too. So
it is possible.
Yeah.
So we don't have to do any of those big things that a surgery requires. Usually you arrive to our department about an hour before the procedure, just to get everything ready. For the procedure, we get access to a small artery in the front of the groin. We use X-ray to guide a catheter using contrast dye over to take a look at some of the pictures, take a look at some of the vessels in the knee, see which ones are abnormal, and then we'll treat them with those microscopic spheres to take care of the new blood vessels. At the end of our procedure, everything comes out of the artery, plug up the little hole we made, and then you just stay with us for 2 hours after the procedure. Most people, like Melissa was describing, tolerate everything very well on the procedure day. So it turns into the whole procedure takes about an hour. So it's about a 4 or 5 hour block of your day that's taken up, and then you get to go home that same day. And really the only precautions, kind of like she alluded to, are weight restrictions, and that's related to our arterial access, the place where we poke into the blood vessel. We just don't want that to bleed, so we don't want too much strenuous activity where that could bleed down the line. So for about a week or 10 days, we say don't lift more than 10 pounds. But that's really your only restrictions afterwards. You'll feel like you can do more than that from day one, but we try to ask people not to do that as a precaution.
Are you able to speak to the patient during the procedure?
Yeah, so that's one of the nice things about our level of sedation. We want them to be, we don't want people to be, a lot of times, it's not that this procedure would be intolerable with no medicines even. It probably would be, but patients don't know what they're getting into, and doing medical procedures can be nerve-wracking for a lot of people. So we don't want people to be nervous during the procedure. If you ever had a colonoscopy or something like that where you have kind of that intermediate level of sedation, we're kind of on a similar level to that, not even quite that deep. What that means is people are aware of us to verbal stimuli. So sometimes people do fall asleep, but if I said your name, you would open up your eyes and then you'd say, what, did you need something? And then if not, then they'll kind of go back to a state of comfort for most of the procedure.
All right, you're going to give us a little lesson, okay? A little show and tell, if you will. So kind of walk us through what we're seeing and what you did inside there.
Yeah, so I described a little bit of the procedure already. So this is after we've already put our catheter into the groin, and we've taken a catheter down, and we're putting contrast dye into the main blood vessel that's taking blood down the leg. Now you can kind of hallucinate back here a couple of shapes. This is the knee joint right here. This is the distal part of the thigh bone, and this is the proximal part of the shin bone. So right here is your knee. So we're injecting this contrast down, and all of these small branches that you see coming off the main tube, those are all geniculate or geniculate arteries. And everybody has a bunch of them. They're taking oxygen and nutrients to those tissues around the knee. What's abnormal is, as you see this contrast go in, you'll see this kind of puff of smoke or kind of cloudy appearance here on the outside of this person's knee. And that's that neovascularity, or abnormal new blood vessel formation. That is the sign, that is the pathology that we look for with osteoarthritis, and that's what we're really going to try to target with our procedure.
And that's causing the pain?
That's what's part of that cycle of pain generation I was describing before. So after we used that first picture to identify which of these geniculate arteries is the one supplying those abnormal blood vessels, we'll use an even smaller catheter and put that into the blood vessel that's supplying the abnormal vessels. We'll take this picture here where we can again see that it is the vessel supplying that area, and confirms that we're going to be able to treat it in a way that's safe and effective. So on the next sequence here, you'll see us actually administering those beads. So this is the same catheter in the same position, injecting beads with the dye in it, and you'll see it slowing down the flow down these vessels. And it does really take a lot of kind of expertise and practice in trying to identify what is the correct amount of blockage, because we really want to block up just the abnormal new blood vessels that are around the knee and maintain flow in the normal geniculate artery. So that does take a little bit of nuance and practice to do. So after we've put in those beads, we'll take out our microcatheter and take one more picture just to show that we don't see that anymore. And that's what you'll see here. So we are back through this base catheter looking at the whole leg, and where we saw that puff of smoke, that cloudy appearance here on the outside of the knee, you no longer see any of that, which is what we want to see. And we still do see flow through that vessel that was going there. So that's a really good target of where we want to be at the end of an embolization procedure.
Then we have the old before and after, which we want to see.
Yeah, this is a little easier way to look at, really, when you look at them side by side like this, you can see how much of a change there really is. So these are pictures with our microcatheter, that small catheter into the geniculate artery that's abnormal. Before we do the treatment, we'll inject, and you'll see that puff of smoke, cloudy appearance, and afterwards we inject again. That stuff is gone, the abnormal new blood vessels, and those arrows are pointing at the normal geniculate arteries that are still having normal forward flow to supply the tissues they're supposed to supply. So this is kind of what a before and after would look like, where we've treated those abnormal blood vessels around the knee.
How soon after would a patient start to feel well again?
So it does take a little bit of time. So the studies show really good responses, but by a month out, they show significant improvement, and you'll keep getting better until about 3 months after your procedure. So at 3 months out is when we expect most people to see their maximum level of improvement, and then the studies would say you're going to stay there for up to 2 years after your procedure. So we tell people to expect it by a month. Most people within a couple weeks have started to feel better already, and some people even sooner than that.
Melissa, how are you feeling so far?
I feel great. And I felt really good, like the weekend after. So much so that I was doing all the stuff that I had always, needed to do that I wasn't getting done. And then I realized, oh, I probably need to slow down just a little because I'm not actually completely recovered, and I don't want to push this too hard. But yeah, I felt great almost right away.
Yeah, how important is recovery? Do they have to be good patients and stay put, or do you?
Well, so like I say, the only real limitations they have are concerns about bleeding. So there's nothing that they can pretty much be up and moving, doing their normal day-to-day activities immediately. We just don't want them doing that heavy lifting because we don't want to pop open that hole we poke in their artery where they would have a bleeding complication. That's really the precaution. But they're going to feel fine. So after about that week to 10 days, then they're free. They just do whatever they want to do. There's no like long physical therapy or rehab or anything like that you would have with a big surgery.
That was the point. Get after it.
Yeah,
Get the surgery and get back to life.
Yeah.
We had mentioned this bridges the gap between painkillers and that total knee replacement. If someone has been using painkillers for knee pain, when should they then consider the GAE?
Yeah, so really it's anyone who feels like their knee pain is uncontrolled with whatever they're trying to do right now. So usually it's going to be patients who they know they have knee arthritis. It's hurting. It's getting worse over time. They've tried medicines. They've tried injections. Those aren't working good enough. And then they're at this decision point. Do I go to the gold standard, which it is still the gold standard treatment, is to go do a knee replacement. And if you can do that, that's fine. But there are a lot of patients who have a lot of limitations on if they can get knee replacements or if they wish to get knee replacements. Yeah. So knee replacements have kind of a limited lifespan. So they last about 30 years. So if you're too young, you don't want to have to get 2 knee replacements. Right. Maybe you want to try to delay getting that knee replacement. That'd be a really good time to come in for a GAE. If you're too old or you have other comorbidities, you have other health issues that make you a poor surgical candidate, where they're saying maybe it's not that safe for you to get a knee replacement right now, that makes you a great candidate for a GAE. So then there's just patients who don't want to do all the rehab, don't want to do all the recovery, and say, I'd rather avoid doing that if there's another option. And that's a great patient for a GAE. So the short answer is anybody who's got pain uncontrolled from knee arthritis is probably a candidate for this procedure.
And it just creates another option.
Yeah, exactly.
Be sure to ask your questions. You can use the chat on YouTube or Facebook, or you can email the Medical News Network. That information is there on your screen. So this is for osteoarthritis, but what about rheumatoid arthritis? What about for those patients?
Yeah, so right now this is only approved for osteoarthritis. There are studies that are looking at other uses for this because it has shown good results, but right now we can't offer it for any type of those other inflammatory arthropathies right now.
So how often does someone get this procedure and then not notice an improvement in pain? Does that happen?
It's not very often. So everything is on a spectrum, so that's why we use big, evidence-based studies to try to guide our treatment decisions. So some people respond a little bit and some people respond a whole lot, but we know on average, when you look at these big cases, people on average when they come in, they start with if you looked at a pain scale from 1 to 10, they are starting at about an 8 on a pain scale, and after our procedure they improve to about a 4. So they don't go to being 0 pain, and we don't promise that. We just promise that their pain is going to get markedly better and it's going to allow them to do the things they want to do with their life. But some people do get all the way back down to a 1 in pain. But for every person that goes down to a 1 in pain, someone only improves just a little bit to get to that same average. So I've only had one patient who really didn't have any response out of all the patients that I've done so far, but there is a spectrum on how people respond. But we know that's why we use evidence-based medicine and data to try to guide these decisions. And it shows that it shows significant improvement with this treatment.
So again, so what are some of the common reasons why someone with knee pain would choose not to get a total replacement, even if they're eligible?
Yeah, so that's a personal decision, but a lot of it is the 3 big ones would be age-related. So like if they're too young, or if they're young enough that they don't want to have to run the risk of having to get a replacement later on in life, that would be someone who would choose not to, or real old when they're worried about the anesthesia. Or if you just don't want to deal with those comorbidities or those prolonged recovery, or people want to avoid general anesthesia that you need, or a long hospital stay, or they have to work to provide for their family. They can't take 2 weeks off work. I mean, there's lots of reasons why someone would prefer not to have to go through that.
All right, Melissa, big important question. What are we looking forward to planting in the garden this year?
Yep, I already went out and bought some plants to put out.
I think we have a picture. This was from last year. This is, tell us a little bit about your garden.
Well, this is actually, I I moved last year, so this is actually my garden from before. But that picture, I'm holding a little ring snake that I had found in my garden, and I was showing it off to the. And so, yeah, I'm really looking forward to gardening season because last year I couldn't do anything.
Robert, what are you looking forward to doing with Melissa now that she's back up and running?
Oh, I'm looking forward to doing things like museums again, or just not having to be the bookkeeper of her steps. You know, I mean, we love museums, or the national parks. We love to go to the parks, but you know, nowadays, before this procedure, it was like, well, if you do maybe the quarter-mile lookout walk, but anything longer than that, we were trying to find the handicap spot. And, you know, the parks see hundreds of thousands of people, so you don't always get a handicap spot. So we're driving past that lookout, you know, and yeah, I'm looking forward to just being able to do stuff and not be the keeper of the steps.
And what about chasing out the grandkids, most importantly?
Yes, because they're still running, and now Nana can almost keep up.
Good. That is job number one. Well, we're so glad that you're doing well. All right, I want to get to some questions from our viewers because we've got a few coming in today. Let's see. Ruth says, sounds like knee pain from psoriatic arthritis is out too. Is that correct?
Yeah, so psoriatic arthritis is also in that other family of other inflammatory arthropathies with rheumatoid arthritis. So really just an osteoarthritic knee pain is what this is specifically designed for right now. Now that is getting spread to other locations. There are some trials out there for hip pain for osteoarthritis, but other forms of arthritis right now are kind of contraindicated to do this procedure on.
Rob just has a comment. He's pretty sure the cost is less than a total knee replacement.
Yeah, so right now everything that we do is covered by insurance too. So that's an important thing to know, is that it is all covered by insurance. But yeah, compared to, and the cost is looked at two ways. Cost for the patient, it's probably significantly less than, just because there's no hospital stay, there's no anesthesia, there's no, big open surgeries or anything like that. But also cost to the hospital system and cost to the greater medical system is a lot less.
Sharon asks, can this procedure be repeated after the pain relief diminishes after a couple of years, as you mentioned?
Yeah, it can. The retreatment rates and the response rates from retreatment aren't quite as good when you have to go back and do it. But if you have someone who's had a really good response and like 3 or 4 years later they're starting to have knee pain again, it's still, we talk about that high risk, low reward. The risks are so low to go in and try it again and see if it helps. It's very worthwhile to go ahead and try. The only people that I would say would not benefit from trying it is if you did this treatment and you never saw a response. The chances of going back in and doing it again and it having a different response, then probably not, doesn't make sense.
Stu wants to know how new the procedure is.
Yeah, so I think I did the first one of these probably 3 years ago, 2 or 3 years ago here at KU, and we were doing them very sporadically because the data was developing, but it wasn't really well established. But recently, over the past year, there's been a whole lot of new research that has come out that have really shown bigger studies, prospective studies that show these good responses, and the durability is the one thing that they've really shown is that you get better, you get a whole lot better, and then you stay better for that long period of time compared to injections, which are only lasting by the time they get to us for people for a month or 2 months or something like that. We get 2 years of that improvement, and as that information has come out, we've been able to really grow and had the support and had justification to grow this as a service line.
Deb asks, can this procedure be used on hips or lower back, other areas of pain?
Yeah, I kind of alluded to that. It's being studied on hip osteoarthritis right now. Low back is not probably going to be something that we use. Obviously, low back pain is a huge problem for a lot of people in the country. Unfortunately, the way the blood flow goes to the low back is not probably very amenable to this type of treatment. But the hip is something that they're evaluating, and there are trials, ongoing trials about that. So if that comes out, maybe someday soon.
And Marty wants to know, can it be used after a total knee replacement?
That's a great question. So the ideal candidate for our procedure, the people who see these ideal best responses, these are going to be people who have moderate to severe pain, so 8 out of 10 on a pain scale. But their x-ray findings are moderate or mild on findings on x-ray. Those are the people that get the best response. So those are the people that we really, really want to push to get this if they are available. But people who have very, very severe findings on x-ray still see some response. It's just a kind of a wider range of how well they do and how well it lasts. And we've had actually even success on people who have had knee replacements already. Now, when I see those people in clinic, I can't tell them I have the perfect answers for them because we don't have studies that look at that I know of. So I can tell them it's the same thing, low risk, high reward option, right? We can try it, and we have had success. We've done it on people with knee replacements, and they've had a really good treatment response afterwards. But if someone comes into me, since we don't have the data, I can't say I expect it to be this or that. I can just tell them the risks are really, really low. We've done them, and people have gotten better, and I think it's probably worth it if you're dealing with this uncontrolled pain.
Yeah. And Melissa is one of those people, and we're so glad she's doing better. Melissa, Robert, thank you so much for joining us this morning. What do you want the big takeaway to be from your story, Melissa?
I think if you're dealing with this, keep asking for, what can be done, because clearly, if I had stopped with that first doctor, I would still be in a lot of pain. And now I'm feeling so much better. So thank you, Dr. Custer. I really appreciate that.
Robert?
Yeah, I'm impressed. Before, she could even be in pain with her legs up and trying to just like uncross her legs. And now, she's walking all over the place. So I'm very happy too.
Well, we're glad you're doing well. Get back to life. Dr. Custer, I know it's great to be reunited with your patients.
Yeah, it is. Yeah, it's great. It's always great to have people who have good responses and it's having a positive impact on their lives. So that's what we're doing it for. And that's really what I want people to know is that if you're dealing with uncontrolled knee pain, there are other options out there. And we're trying to get the word out as much to the referring doctors as much as possible to know that we're getting these good results. So I agree. Keep asking questions and just know that there is this treatment option that can give you relief if you're not getting it otherwise.
Thank you so much for being with us today. Appreciate your expertise.
Yeah. Thank you for having me.
Thanks to all of our guests today. Thanks to our viewers for being with us. Have a great weekend, and we'll see you back here on Monday. Coming up Monday on the Morning Medical Update, this ultrasound tech scanned herself and spotted her own tumor at just 29 years old. I'm Jessica Lovell on the next Morning Medical Update. A lucky catch that influenced her treatment. Monday at 8.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcast. Now everywhere podcasts are available.